Next, I'd like to ask Dr. Ni, do you have any comments or question to Dr. Wakelee or to Dr. Huang?
Okay. Thank you, Professor Zhou. Thank you for the Professor Wakelee's excellent presentation. So we can see in our perioperative therapy, I think the 4-year perioperative immunotherapy is not necessary for all patients. So we should, the pathological response, I think we should assess the ctDNA MRD, just as you said, is also an important help us to have the decision. So I have a question. So in your clinical practice, so if the patients get a PCR, the pathological response is PCR, will you give him or her the adjuvant immunotherapy? That's my question. Thank you.
Thank you. That's a very important practical question. So in the United States, we are launching a trial through our cooperative group system that's asking that exact question. For patients who have a pCR, they're randomized to get adjuvant immune therapy or not. And in Europe, and I know in parts of Asia, there's similar studies being done. For today, right now, though, in my practice, when a patient comes in, I talk with them about the data that we have from Checkmate 816, showing that in the setting of a pCR, the likelihood of additional benefit is low because they already have such a high likelihood of doing very, very well. And that additional treatment we know can lead to increased problems. I have one patient I always think about who had not quite a pCR, but very close. And he had done very well with his preoperative therapy. But when I gave him adjuvant immune therapy, he developed very significant endocrine disorders and is still very bothered by those, right? And so maybe it also set off a strong immune response, and that's why his cancer has not come back yet, but maybe he didn't need it. And so I think that for today, I have a conversation. I tell patients I would be comfortable not treating, and that many of the regimens that have overall survival did include it. So until we've done these studies, we don't know for sure.
Okay, thank you very much. So I have another question. Will you combine the PCR, the path assessment and the ctDNA MRD status, combine them together to guide your clinical therapy?
So where we have data, the Checkmate 816, right? The pCR, I showed the slides from the pCR and not, and that give a very clear story. The ctDNA studies that we have seen across multiple trials now have all also been relatively consistent that if you have no evidence, or if you have evidence of ctDNA, your prognosis overall is not as good. And most of them have shown that by adding in that immune therapy in the adjuvant setting, patients do a little bit better. But if there's no ctDNA detected, they do better than those who did, but you still have a lot of patients with recurrences. And the trials that we have, so from Empower O&O, Professor Zhou's analysis showed that even in those without ctDNA detected, there was still a benefit from atezolizumab, which says the detection wasn't good enough, right? There were still patients who had risk of recurrence and they were getting that benefit from adjuvant therapy. So I think where we are right now is hints that if we see ctDNA, it's a poor prognostic factor and intervening has helped some patients. And if we don't see ctDNA, the tests aren't good enough to tell us that we can be comfortable not treating. But those assays are getting better and better and better. And maybe with ctRNA, like I said, maybe that's even going to be better. So maybe we can get to a point where we can be comfortable saying, well, if there's no ctDNA detected or liquid biopsy, whatever we're testing, then we can be done and we don't need more treatment, right? That would be much more helpful, but we don't have that data yet. So for right now, the pCR is very strong results. And the ctDNA, if it's negative, I don't know what to do with it. If it's positive, I know it's not good and I definitely need more treatment.
Yeah, okay. Thank you, sorry, for your excellent answer. Thank you.
So, nowadays we have so many good compound approved in advanced stage of lung. We have ADC, we have bispecifics. So I have question for all of you. Which compound should we study in the early stage of lung cancer, neoadjuvant or adjuvant setting, bispecific or ADC? I like to start with Dr. Huang,
I don't sure, but I think low toxicity is a good choice.
Okay, that's it. That's good. Great answer, Dr. Ni.
So I think as a ADC is chemo version 2 and as a bispecific is the immune version 2. So I think maybe we could combine these two drugs to do the perioperative therapy. This is my opinion. Thank you.
Yeah, Dr. Wakelee, what's your choice?
It's tough. I think Dr. Wang's answer is very important when we are thinking about these treatments where we don't know how much we're helping. We can't track in real time. Maybe in the neoadjuvant we can, but certainly not adjuvant. We have to be very aware of the long-term toxicities, and so that's important. With the ADCs, we're bringing in chemotherapy, and so of course that would just be for a shorter time, maybe in the neoadjuvant. I think with our bispecific so far, we haven't found those that don't have some toxicity. I mean, obviously there's a lot of excitement about the VEGF and PD-1 combined bispecifics, and I think it is worth exploring those. But I will remind everyone that my first big adjuvant trial, ECOG 1505, looked at adjuvant bevacizumab and was completely negative. And so we have to remember the past, even if it's a long time ago past, as we look to new drugs of the future. So it's important to investigate. I think that it's nice with neoadjuvant because you get some answers soon. Adjuvant trials take a long time, but we have to be mindful of all of those things as we move ahead. So.
Yeah, thank you very much, for your excellent discussion. I'd like to say that we have to move on. So Dr. Zhang,